All right. I am thrilled to introduce Robin Jones with the Royal Marsden, UK. Professor Jones will be discussing the role of local therapy in multifocal epithelioid hemangioendothelioma. I think it took me about 4 months to learn how to pronounce that after I was diagnosed. So a warm welcome to Professor Jones. Thank you so much for giving us your time today.
Great. So thanks very much for the invitation. I hope you can all hear me. And similar to Scott and Sylvia, I'd like to say that it's such a great pleasure to be involved in this lecture series today, and a big thank you. This is going to be a very brief presentation, and I think it's probably better and more useful to have a little bit more time for discussion at the end. And this all sort of revolves around questions that patients have asked me over the years in clinic regarding the role of local treatments when they've got multifocal or multiple areas of EHE. And given the lack of evidence base, we decided to do a study of the database at the Royal Marsden to look at this. So these are my disclosures. And as Scott has mentioned, local therapy clearly has a significant role in the management of localized EHE. But as Scott mentioned, very often this entity can affect multiple sites, particularly in the liver. And there's a spectrum of clinical behavior. And very often the disease can be relatively indolent or slow growing. But sometimes we're confronted with one area that may be growing while other areas are stable. And sometimes there are symptomatic areas of progression, particularly in bone. And there are clearly a variety of local treatments available to treat cancers, but the therapeutic algorithm in EHE is not well defined. And the evidence base for selecting local therapies similarly is not well defined. And one of the crucial things for this entity is that conventional chemotherapy has, if anything, limited activity. So this means that local therapy, particularly if overall the disease is stable, can have a really important role. So as has previously been mentioned, there have been a number of series published looking at the outcome of patients with EHE. This particular multi-institutional study reported a 5-year survival of over 90%, and median age was just over 38 years. One of the things that I'd notice is that there are a number of studies that have been published reporting the benefit of minimally invasive surgical techniques in EHE, with a number of reports on the role of laparoscopic resection, which is important to bear in mind, particularly to try and minimize the morbidity of surgical intervention. And that's even more important in the context of multifocal disease, where we may be focusing on just one particular symptomatic or problematic area. As I mentioned, the role of systemic therapy in this disease is not well defined. Some of the previous studies that have been done at the Royal Marsden Hospital have suggested that conventional sarcoma-type chemotherapy may not be as effective in this particular subtype. Of course, Sylvia and her team have published a study on the use of sirolimus recently. But given the potential toxicities of systemic therapy, if there is solitary progression, this really does make us reluctant to consider potentially toxic chemotherapy for just one area that's causing problems. So radiation is well established in the treatment of many cancers, and there are many case reports and case series going back to the 1980s on the role of radiation in EHE. And of course, this technique is widely available. A number of reports have suggested that this can potentially be used as primary treatment for bone disease, but it's very useful in terms of symptomatic bone progression, particularly if the bony area of disease is causing pain. So very often patients ask about interventional radiology techniques, and there are a number of techniques available, including embolization, radiofrequency ablation, cryoablation, microwave ablation, irreversible electroporation. And I know one of the next speakers is going to talk about IRE, but all of these techniques can potentially be useful. And one of the things that we noticed from a previous study at the Royal Marsden was that these techniques can be particularly useful in the context of solitary progression when the rest of the cancer is stable. And of course, there's this famous case report of IRE published in the Journal of Clinical Oncology 7 years ago now. And this is a very interesting technique, not available at every facility, but a number of reports have highlighted the usefulness of this technique in EHE. And it'll be a pleasure to listen to Dr. Narayan's lecture in a few minutes. We've treated a patient with this technique with durable disease control, but from our study of multifocal disease treated with local therapies, we used a number of techniques, so not just IRE. And this gives the This slide gives the characteristics of the patients with multifocal disease that we treated with local therapies, and you can see that there are a number of anatomic sites involved all over the body. And I think my slide. Can you still hear me? There we go. Great. So we used a number of treatments, including surgery, liver transplantation, radiotherapy, radiofrequency ablation, IRE, and endovascular embolization as well. So just to highlight that all of these techniques require the input from a multidisciplinary team. But the crucial thing, that we learned from this study, that there were very few toxicities as a result of the local treatments that we used, and the rate of progression at other sites of disease around the body was relatively low, so 7.5%, only 4 patients. So our conclusions were that local therapy definitely has a role in a selected cohort of patients with multifocal EHE, that it's important to have multidisciplinary team input to manage patients, to provide them with the optimal treatment available, and that local therapies are particularly useful for solitary areas of progression or symptomatic areas of disease. And this busy slide from the manuscript just basically shows that this cohort of patients had a very, very good outcome following treatment. So as I say, local therapy clearly has a role in multifocal EHE, particularly for solitary disease progression or symptomatic lesions. there are multiple options available, and multidisciplinary team input with medical staff that are familiar with dealing with this very rare disease is very, very important, and has been highlighted earlier today and last week. International collaboration is vital in order to improve our knowledge and treatment of this rare disease. And I think the initiative that Sylvia instigated is absolutely fantastic, bringing all of these people together to try and make things better for our patients and to improve the treatments available. So I told you I'd be very quick, and it's much better to have more questions rather than me just talking and talking. I'd like to thank all our patients at the Royal Marsden, but also the multidisciplinary team, their names listed there. So with that, I'll say thank you, and I've probably made everybody really, really confused or really bored. My hair's a bit longer due to COVID in that cartoon, as you can see. I've subsequently cut it.
I would take that as a problem personally. A couple questions have come in here. What is a typical case or outline of care that would require the use of sirolimus?
I think if the EHE is progressing rapidly, if somebody is symptomatic with the disease, then we would consider treatment with sirolimus. I think, given the evidence available, sirolimus is a very, very good option for patients with EHE. And in essence, I think for patients with symptomatic disease, widespread disease that's getting worse on scans, I would consider treatment with sirolimus or another form of systemic therapy.
This next question is one that's come up quite a bit over the last session and this one. What are your thoughts about the use of checkpoint inhibitors or other immune therapies and tests?
Yeah, I think that's a great question. I think the answer right now is that we do not have definitive prospective evidence of their efficacy in this disease, but they certainly warrant investigation. And one of the things that we always discuss with patients, so if a patient is due to start, an EHE patient is due to start sirolimus, or any other systemic therapy, we always ask what are the clinical trial options that are available to us. And we're very fortunate at the Royal Marsden to have a drug development unit that has a number of trials that include immune checkpoint inhibitors. But one of the fortunate things over the last 6 to 12 months, we've not really had many EHE patients that have required systemic therapy, which in a way is a good thing. They've carried on with active surveillance. But that's something that we always check. Is there a clinical trial, particularly a clinical trial incorporating an immune checkpoint inhibitor?
Marsden has most of the tissue samples in-house. Is it feasible to extend your study by correlating genetics and histology with the outcomes of local intervention?
Yeah, I think that's a very good question. So I think the short answer is yes. I think there are logistical issues with that. There is a lot of bureaucracy in the UK, but in conjunction with other studies that we're doing, I think it will be possible to look into that, particularly as we're fortunate to have the database as well. But that would be a very, very interesting question. The samples are actually stored a few hundred miles away, but it's possible to get them, even during the COVID pandemic.
That's good to hear. Is there any association with the discussed local therapies and hyperprogression of unknown EHE left behind?
No, that's in our series. That was we did not observe that. As I mentioned, our patients did really, really well. I think the majority of those people had relatively slow, relatively indolent and slow disease, but we did not observe hyperprogression, even with the patients treated with surgery. Sorry.
Oh, no problem. Thank you.
Yeah.
Next question that came in.
Oh, carry on.
Oh, no, please do complete your answer.
It's sometimes there's a lot of debate regarding the value of surgical resection of metastatic disease. Sometimes the surgical procedure itself can almost, as was mentioned, result in accelerated growth of disease that's not been removed by surgery. But in our study, I suppose in a way, because the patients were selected and probably had a period of surveillance where we made sure that the disease was slow before undergoing surgery, we did not observe hyperprogression. But that's a very very difficult judgment call in many ways, and it requires close discussion with individual patients and their families.
Any comments on radiological application to soft tissue areas, for example, veins and organs?
So in terms of radiation therapy or just radiological assessment?
I'm not sure what the question asker asked, so let's, if possible, maybe address both of those.
So as was mentioned, I think sometimes the assessment of the disease in the lungs using radiology, using scans, can be challenging. And I think there's a lot that we need to do to try and understand the disease process when it affects the pleura. In terms of assessment of the disease elsewhere in the body, I think the liver, bone, other structures within the abdomen, the radiological techniques that we have available are relatively good at monitoring and detecting disease. And as Scott mentioned, very often the disease is picked up coincidentally. So I think for those other areas, we've got the available radiological modalities are pretty good. In terms of using radiation treatment, I think if there is a soft tissue tumor that's causing symptoms of pain or pressure, then radiation is a very good, tried and tested treatment for an area of EHE that's causing symptoms. I'd welcome a follow-on question. Good.
Yeah. So with the different imaging you have, how long do scans have to show disease progression before? And this is a hard question because the answer I know is it depends. But can you speak to how long the scans have to show progression before you make changes in the treatment modality?
Yeah, that's a great question. I often use how long is a piece of string as an answer. But I suppose in certain ways, for as long as we possibly can. Clearly, if if somebody is not feeling well and they have increasing symptoms, we go by the way that somebody feels rather than waiting for the next scan. But I think that's very individualized to a specific person and their disease location and the symptoms that they have. And that's again the importance of having a multidisciplinary team of people to look after somebody, to make sure that every speciality has a sort of input into management.
We've got a question here about drug options, and specifically, can you speak to how long one can stay on the available drug therapies and what the long-term effects are?
Yeah, so again, that's a fantastic question. For certain treatments, so certain standard chemotherapy drugs that are used in sarcomas in general, so for doxorubicin, for example, due to the cumulative risk of heart damage, there's a set limit in terms of 6 cycles of chemotherapy. Other drugs such as ifosfamide can also be very toxic, and it's unusual for people to carry on with a toxic treatment like that beyond 6 or 8 cycles. And both of those drugs have chronic or long-term toxicities, which are quite serious. So as I mentioned, doxorubicin can cause heart damage. Ifosfamide can cause damage to the kidneys. Both can very rarely cause secondary cancers as well. So if there is somebody with an indolent disease, it's important to be really sort of thoughtful about using potentially toxic drugs like that. With some of the newer drugs such as pazopanib, I suppose we don't really have full sort of long-term information regarding their chronic toxicities, but again, they often require dose adjustment, dose reduction, depending on side effects. And chronic fatigue can be really even if it's low grade, it can be quite sort of disabling. So again, there's no sort of set answer in terms of, you should be on it for X length of time, but it's a constant discussion with the treating doctor and the patient about the relative benefits in terms of treating the cancer, but also in terms of the side effects that a person's experiencing. So I don't think for an individual person there's a set length of time for some of these newer agents, but it's constant communication and dialogue between the treating doctor and the patient. And as I say, for some of the newer drugs, we don't have full information regarding their long-term toxicities.
Thank you so much, and we're out of time. There are a number of follow-up questions in the chat in the main session if you want to check those out and respond to them, but otherwise we will turn back to Jenny for the next speaker.
Fantastic.
Awesome. Well, thank you very much, Professor Jones, and special thanks to you spending your Friday afternoon and evening with us. This is the second time now we have seen that slide with the many faces, 80 experts that came together at ESMO. It is so important and appreciated that this collaboration is occurring regarding patient care. So thank you again so much for being here with us today and your dedication to EHE patients.